preventing cell growth. I'm sorry, I think I've come out of the. So yeah, they're capable of preventing cell growth and destroying cancer cells. And we also know from last week's presentation as well that they have chemotherapy drugs have action on all cells. Cells that have the highest rate of proliferation, or in other words, cells that are rapidly dividing. So tumor cells are one example. They tend to divide and replicate very fast. Cells of the epithelial cells, bone marrow cells, and germ cells. So if I think about BMT specifically, this I got from the BMT manual that you use in your settings. Most common agents that are used in the pre-transplant conditioning regimen are these. So you all probably have used or administered these agents. So we have ATG, busulfan, cyclophosphamide, thiotepa, and fludarabine. So if you're paying attention, there's a question at the end on this. You will see that most of these drugs, except fludarabine, are alkylating agents. Again, I'm not going in too much details of the mode of action because we had a lecture on this last week. Alkylating agents are generally agents that prevent cell from dividing and replication by attacking the DNA of the cell. So that is alkylating agents. So moving forward, chemotherapy exposure. So why are we talking about safe handling of chemotherapy? Why does it have to be safe? We know that chemotherapy is toxic, but it's not only toxic. The risk of chemotherapy exposure is not only limited to the patient. We know that when you give patient a chemotherapy, it produces side effects, and because it's toxic to the body. But the chemotherapy is also, there's a risk to the environment in which chemotherapy is prepared, and also risk to the operator. So the nurse or the pharmacist that is preparing or administering the chemotherapy, they are also at risk of exposure. Again, on this slide, you can see who is at risk of exposure. So personnel who are involved in all these processes. So from procurement of the drug, from the drug company to the preparation, to the dispensing of to the clinical areas. So when it comes from pharmacy to your ward, the administration, containing a spill, waste disposal. So everyone who is involved in all these processes are or is at the risk of exposure. Now, what is the risk? I think that should be the next question. So these are the risks. Basically, chemotherapy agents are capable of causing birth defects. So during the gestational period, for pregnant ladies, it has the potential for increasing or causing cancers and genetic changes as well. So the handler or person who is dealing with chemotherapy can absorb chemotherapy through different routes. So you can see in this picture, firstly, we have inhalation. So if chemotherapy becomes aerosols, if there is aerosol production or vapor production, then you can inhale it during preparation. It can also be absorbed through the skin and mucous membrane. So direct contact, if chemotherapy drops on your skin, it has the potential to absorb through skin and mucous membrane. Parenterally, if you have, while you're preparing or administering, if you have a puncture or a sharp accident, that can also lead to chemotherapy exposure. Oral route is there as well, careless or accidental ingestion of contaminated food contaminated with chemotherapy. But I think it's also important, while we're discussing about the exposure and risks and hazards of chemotherapy, we have to remember that the hazards exist in every workplace environment. So even if you take chemotherapy out of the picture, COVID has taught us that there is hazard everywhere. You can catch COVID uh, really in any setting. Or if you look at it in a different way, if you are in the hospital setting and you're not taking precautions, you can catch an infection. So if you're working in, let's say, intensive care, and you're not following the standard precautions, you can easily catch an infection from a patient with an infectious disease. So what I'm trying to say is that hazards exist in every workplace environment. It's not only limited to chemotherapy. What we need to think about or focus on is how we can control the risks. And in this picture, you can see that the actual risk to healthcare workers from chemotherapy depends on, I want you to focus on the last two things, how the drugs are handled, how they are manipulated, and how often they are handled. And secondly, the exposure controls in place, engineering controls, PPEs. We are going to look at it in detail later on. So there are many ways to control the risks associated with chemotherapy exposure. And these are the three main risk controlling strategies, which are evidence-based. So first of all, we will look at the engineering control. We have engineering controls, administrative controls, and PPEs. So let's look at engineering control. Engineering control mainly means biological safety class 2 type B cabinets. So you can see in the image here, the image of the biosafety cabinet. I don't know, the information I got from Sandeep was that chemotherapy is prepared in a pharmacy by a pharmacist. So, but that wasn't the case a few years back. When I was a BMT nurse, we used to prepare chemotherapy ourselves. That has changed now across the world, but still there may be some centers where nurses have to prepare it. So I have worked in the biosafety cabinet. The features of a biosafety cabinet, I think the two main features are that it has vertical laminar flow and HEPA filtration. So it provides a sort of decontamination, sterile environment, and air is blown from the top of the hood straight down. So if there are any particles that can come towards the nurse or the pharmacist who is preparing the drug, because of the air blown from top to down, the risk is significantly less of that droplet or the particle to come towards the one who's preparing. It usually goes down. And you can also see there's a glass at the front to protect from any particle or spills coming towards the handler. The best practices, and we know this from evidence, that a pharmacist should prepare, or even a pharmacy technician who has gone through the training and competency should prepare chemotherapy. But there are exclusive cases, as I said, where a doctor or a nurse usually has to prepare chemotherapy in some settings. I think another good thing about Chemo Hood is that it provides exclusive and dedicated space for chemotherapy preparation, which is a restricted space. So this can significantly control the risk of exposure. Number two, we're going to look at the second risk controlling strategy, which is administrative control. So in administrative control, institutional policies and procedures should be in place. So mainly these policies and procedures should be in place for prescription of chemotherapy, preparation process, safe transportation, chemotherapy storage, administration process, and the use of PPEs. These policies should always be evidence-based and regularly updated. And there should be a training and competency evaluation system for nurses who are preparing and administering chemotherapy. The training, they should be getting trained during their orientation program. So when they join the unit, and even when they have joined, there should be a continuing education program and an annual competency evaluation. So every year, the nurse should be evaluated for chemotherapy administration competency. Next, the third risk controlling strategy is PPEs. Everyone is aware of that. PPT means gloves, gowns, respiratory protection, eye and face protection, head, shoe, and sleeve protection. So firstly, we'll look at the gloves. For chemotherapy, single pair of gloves can be used when you're receiving the drug, you're storing the drug, dispensing it, or administering oral chemotherapy tablet or capsule in a unit dose container. But otherwise, you will have to wear double gloves. So when you're handling uncoated tablets, you're preparing or administering chemotherapy, handling chemotherapy, contaminated body fluids, when you're cleaning up spills or cleaning the biosafety cabinet, you should wear double gloves. Then we have gowns. So there are standard gowns and there are reinforced chemotherapy gowns. I think whichever one you are using, it's important that the gown should be, water resistant, or the water shouldn't get absorbed into it, into the gown. So when is the gown required? In all processes in which chemotherapy is handled and there is a risk of spillage or leak, you should wear a gown. But again, when you're giving a tablet or a capsule oral chemotherapy, which you didn't have to crush, then you don't have to use the gown. Eye and face protection. So face shield and goggles should be worn, maximum protection of face and eye from splashes or spillage. So every time chemotherapy is administered, face shield and goggles should be worn. When you're cleaning up a spill, these should be worn, or whenever there's a risk of splashing. When you come into contact with vomit or saliva droplets when administering oral chemotherapy, again, face shield should be worn to protect yourself from the splashes of vomit or saliva. Chemotherapy by any route with risk of splashing with the liquid. If there's liquid involved and there's risk of splashing, face shield or goggles should be worn. Respiratory protection, we all have seen N95 masks or respirator during COVID times. So the N95 mask protect against airborne particles, and excuse me. So it is not recommended for the routine administration of chemotherapy, but it should be used when there is the risk of spills and leaks. So when you're containing a spill, whether it's big or small, you should wear the N95 mask. So that was about chemotherapy preparation. We looked at administrative controls, we looked at engineering controls, and we looked at the PPEs. So after preparation, once you have prepared the drug, we move on to the next stage, which is chemotherapy administration. So this is the administration process, which starts from the prescription, preparation, transportation to clinical areas, administration, and then after administration, we have waste disposal, handling body fluids, management of exposures and spills. So we'll go one by one. Firstly, chemotherapy prescription. I'm sure, actually, I know this is happening in most of the units where the participants are from, that a qualified professional who is authorized by the institution is responsible for prescribing chemotherapy and signing the prescription manually or electronically. So that is important. As we know, with any medication administration, the verbal prescriptions or verbal orders are not allowed. So that should be always discouraged. In fact, that's a red line. No one should do that. It is recommended to use standardized forms, pre-printed or electronic forms to prescribe chemotherapy, which is happening. So after prescription, we have preparation. We've looked at it already. Just to reiterate, the evidence suggests that it's best when a pharmacist or pharmacy technician prepares chemotherapy. But again, we've said there are exceptional circumstances where a nurse or even a physician has to prepare. But whoever is preparing, you have to make sure that they have a documented record of education and annual competency evaluation. So for safe chemo preparation, again, we've touched upon this, should always be prepared in a biosafety cabinet, maintain aseptic technique, wash hands, wear appropriate PPE, keep the spill kit in the preparation area. And some further safety measures during preparation. So this is relevant for IV drugs. So every time you're preparing, I mean, we all have done that whenever you're trying to pull the medication into a syringe from the container or from the vial, it's very tempting to then tap the syringe and expel the excess medication from the syringe. Usually, when it's not chemotherapy, you can waste a little bit if it's extra. But this should be discouraged when it comes to chemotherapy. You should never expel the excess medication into the air. It should be within the container or the vial. Prime IV sets with a compatible solution that does not contain drugs before adding cytotoxic drugs. So an example could be you want to give cyclophosphamide in a 100 ml normal saline bag. So before you add cyclophosphamide in the bag, you should prime the IV set beforehand so that the IV set contains normal saline, and then you add cyclophosphamide in the bag. Affix a danger drug warning label to the solution. As you can see in this second picture on the bottom, that there is a label attached which says cytotoxic. Use a sterile absorbent cloth with laminated backing. So usually you should always have a gauze when you're priming the IV set or preparing the medicine. Always work below eye level. So for transportation, when your chemotherapy should be transported directly into the clinical units. And it should be transported in a strong, thick-walled container that minimizes the risk of breakage or leakage. You don't want the drug to be, if it breaks or leaks, then you're contaminating the environment with the drug. Transportation containers must be properly signed. So you can see this biohazard sign image here. This should be on the container in which it is transported. Pneumatic tubes should not be used because there's high risk of breakage and damage in the pneumatic tubes. So when you've prepared the drug, next thing is chemotherapy label. So the label should contain this detail that you can see here: patient name, drug name, dose, administration route, total volume required to administer the drug, date of medication, date of administration, expiration date or time, storage conditions, where it needs to be stored in the fridge or somewhere else, prescriber's name, and all of these details should be on the label. So this was an interesting study conducted. It was a prospective study. And we know that medication errors is a big problem. And this particular study looks at chemotherapy drug errors. So over the period of 2 years, they looked at chemotherapy errors on an oncology ward of a large hospital. And over 2 years, they identify 144 errors in total. 39% involved over or underdosing. So there were wrong dosage. That was the highest number, like the biggest error that they found. 21% involved schedule or timing error. So if it was supposed to be given at 9 a.m., it was given at 10 or 12, something like that. 18% of the time it was the wrong drug, and 14% of the time it was given to the wrong patient. So this is really serious. I think we know that the toxic effects that chemotherapy drugs can have, and more importantly, the patient outcomes is very much dependent on chemotherapy drugs given as per protocol. So that is something that I wanted to bring to your attention. So how can we reduce or prevent these errors? I think if we implement some checks along the lines of when you're preparing and administering chemotherapy, if you focus on these checks, it's very likely, and again, this comes from the research, that chemotherapy drug errors can be reduced. So before administration checks are that you verify that there is an informed consent, you educate the patient and family on treatment, side effects of the drugs, and sign and symptoms of those side effects. You review the patient's clinical record for lab test results, which medications they regularly take, which comorbidities do they have, adverse effects presented to therapy in the past, presence of sign and symptoms of toxicity, history of allergy. Again, before administration, you should also check the medical prescription, recalculate body surface area and dose of each drug, determine patient's ability to take chemotherapy according to the route. Can the patient take this drug? I mean, if it is an oral drug and they have like severe mucositis and they're unable to swallow, then you should think about that. Administer pre-medication, hydration, and antiemetics as required. So these checks should be done pre-administration. Also, before administration in the nursing station, the nurse should be wearing PPE, prepare necessary supplies and equipments, check the label on chemotherapy drug against the prescription. This is an important check. And most importantly, you can see it in the red highlighted. Independent double checking has shown to reduce errors significantly. So there should be a double checker or another nurse who's a verifier who should verify the drug against all of these things. So checking the label on the chemotherapy drug and the prescription. Then the double checker should also look at the 7 rights: right patient, right dose, right route, right medication, right time, right fluid and volume, right compatibility. And both the administrator, the one who's administering, and the double checking, both two people should sign the medication administration record form. Those were the pre-administration checks. Now, during administration, administer chemotherapy according to the route indicated, monitor the patient according to each chemotherapy side effects, and educate patient and family about side effects that can occur during administration. After chemotherapy administration, remove all chemotherapy waste and PPE and place it in the cytotoxic waste container. Again, we will look at the waste disposal in the next few slides. Document the end of treatment and educate the patient and family about possible side effects. So chemo administration routes, of course, there are many routes that, for example, oral, IM, subcutaneous, intrathecal, and IV. But in the interest of time, and I know that in our setting, we mostly are using two routes, that is oral route and IV route. So we'll look at these two routes. So first, let's look at the oral route. It is the widely used route. So during oral chemotherapy administration, special consideration should be given to, for example, if it has to be administered on empty stomach, then special consideration should be given to that. Repeat the dose if the child vomits within the first 30 minutes of administration. Observe the child while taking the medicine. Important point to remember here is do not crush oral chemotherapy unless it is in a biosafety cabinet. So if you have to crush it, if it's being advised or indicated, then it should be done in a biosafety cabinet. Next is commonly used route is intravenous route. So usually two types of venous access is used. One is central and peripheral. So with peripheral venous access, you have to wait at least 72 hours. Again, these are the precautions that we have to take. Wait for at least 72 hours before performing a distal venipuncture to a previous site on the same extremity. Veins of the forearm are preferred. Avoid puncturing the child's lower extremities and dominant hand. Secure the catheter or a cannula, always leaving the insertion site visible so that signs of extravasation can be observed. Then we have central venous access devices, tunneled catheter, PICC lines, and implanted catheters, portacats. So for central, IV chemotherapy administration, the checks are that you should check venous return every time you're before administering chemotherapy. If there is no blood return, then and if it's a peripheral line, then you can insert a new IV access, because if there is no blood return, then it's likely that the IV cannula is either blocked or it's not in the vein, it's got out of the vein. And if it's a central line and there's no blood return, then don't administer IV chemotherapy. You must inform the doctor, or if you have a central venous access device specialist nurse in your setting, you can inform her as well, him or her. For vesicant drugs, new IV access if the line has been in place for more than 24 hours. This is the standard. So mainly, always check for blood return before administering IV chemotherapy. Some more precautions. So if you're giving direct bolus infusion, which is less than 5 minutes, then you should check blood return every 2 to 5 ml. After every 2 to 5 ml of the bolus infusion. Assess the patient for pain at the IV site. So you can ask them after every few sort of 30 seconds for pain at the IV site. And if there is pain, then you will stop and investigate what is the pain, because you don't want the drug to be going outside of the vein. Intermittent infusions, 15 to 90 minutes infusions, or continuous for several hours infusion, are always administer those using an infusion pump. And there is a word of precaution here, highlighted there in red. Do not administer vesicant chemotherapies through peripheral line using an infusion pump. The reason is because if the line is not in the vein, then with infusion pump, there's a risk of drug going into the surrounding tissues. So check venous return according to institutional policy. Assess IV site hourly for inflammation, swelling, and pain. So even when you're giving IV infusion through central line, that is true for that case as well. Monitor the patient during the infusion. After IV administration, recheck venous return, flush the IV line with normal saline solution using a push-pause technique, reassess surrounding tissue of infusion site for extravasation, remove or heparinize the venous access device as appropriate. I mean, you don't have to remove the central line, of course. If it's a PICC line or a Hickman line, tunneled catheter, you will heparinize that. Unless there is a continuous infusion going, then you will put that infusion on. Dispose of chemotherapy waste according to local policy. We will look into that in a minute, and document. So you've given the medication, you've prepared, you've administered, and now comes the waste disposal. So waste disposal, the container that you're going to use for waste disposal should be rigid and airtight. It should be waterproof. Usually hard plastic containers are used. They're waterproof, resistant to perforation and easy breakage. So if you're putting sharp, usually sharp boxes are separate. So when you have to dispose of needles, they are usually disposed of in a sharps container. And the other things can go in another container. But the sharp container should be resistant to perforation, even the other one. And the container should not be filled more than 3/4 full. So if you see that it's 3/4 full, then you should not use that. You should seal it and send it off, and you should take a new sharps container. They should not be in places where direct patient care is performed. Body fluids. So urine, stool, and vomit must be considered contaminated during chemotherapy administration and up to 48 hours after chemotherapy, once it's administered. How do you handle body fluids? So body fluid from patients receiving chemotherapy up to 48-hour, double flush in the toilet with the lid closed. These are the recommendations. Dispose of diapers in the cytotoxic waste container. Linen ideally should be disposable, but if it has to be washable, then it should go in a leak-proof plastic bag, and it should be treated as contaminated. Use a waterproof cover in the patient bed if available. So what to do if an accidental exposure happens? Of course, accidental exposure can happen in any setting. Even when you have all the controls, accidents can happen. What to do? So if an exposure occurs on PPE and skin contact is not involved, so without skin contact, then you simply dispose of the PPE. So gloves, apron, if you're wearing the face shield, you should dispose of that in hazardous waste container. Usually it's color-coded, so according to your institutional policy, it should go in the chemotherapy or hazardous waste container. But if exposure occurs on the clothes, then remove and treat the clothes as hazardous. Contaminated clothing may not be taken home to be laundered. And in each case, you must wash your hands in water. So if the exposure occur to the skin and mucosa, then the guideline says that you should wash the affected area with mild soap, not antiseptic, and under running water for at least 10 minutes. And you should report the event to the occupational health department, and they can further give you the guidance. But this is the guidance for if the exposure occurs to the skin and mucosa. If the exposure occurs at eyes, then remove contact lenses if you wear them. Flush under running water or eye shower or a saline solution for at least 15 minutes. And again, report the event to the occupational health department, and of course to your supervisor and your colleagues, so they know that you have had an accidental exposure. Request medical assessment as soon as possible. Chemotherapy spill. So again, like accidents, exposure accidents, chemotherapy can be spilled accidentally anywhere, and spill can occur in any of the processes in which chemotherapy is involved. So preparation, administration, and during waste disposal as well. So it is essential to have a spill kit. We discussed that earlier, and the spill kit should be available nearby. Units where chemotherapy is prepared and administered in an accessible location, and staff should be aware where to access it. Must be cleaned up as soon as possible by properly protected and trained personnel. Again, spill kit training has to be, it is also a competency which should be maintained on a yearly basis. So as soon as the spill happens, must be cleaned up as soon as possible. These are, you can see, these are the contents of a spill kit, usually PPE with a respirator N95, absorbent plastic backed sheets and spill pads, disposable scoop and brush, puncture-proof containers, large heavy-duty waste bags, and a danger sign. So you can review your spill kits that you're currently using, and you can review your spill kit against this. These are the steps in case of a spill. Again, this is part of one of the questions. The first step is to immediately evacuate patients and staff from the area and obtain a spill kit. Then you put the PPE on, you put the danger sign there, you limit the spread of spill by covering it with absorbent pads and cleaning up the area. Clean the spill area thoroughly with a detergent solution followed by clean water. Dispose of all contaminated material in chemotherapy waste bag and seal it. Remove PPE, discard it in a chemotherapy waste container. Report the spill according to institutional guidelines. So these are the references where I got all the materials from, and thank you so much for listening.
Thank you,
Sandeep,
Sulman.
if you're happy